Patient has a chronic history of dyspnea and cough.
I'm provided with radiograph chest frontal projection of an adult patient in which I can see that there are fibrotic changes and interstitial thickening with the reticulations in bilateral upper and mid zones. There is relatively sparing of the lower zones. I can see that bilateral hilar are also pulled upwards. The cardiomediastinal contours, they appear normal. Diaphragms are clear. I cannot see any pleural effusion and there is no pneumothorax. I'm looking at the bones which appear normal. So to conclude with my findings, fibrotic changes in bilateral upper zones
Excellent.
with the reticulations. The differentials for these findings could be advanced stage of sarcoidosis. The possibility could be of fibrosis due to tuberculosis. If there is any history of radiation, I will also keep that in differentials. Extrinsic chronic allergic hypersensitivity pneumonitis and ankylosing spondylitis will be the differentials for this. I will convey my findings to the referent physician, will compare with the prior imaging if available to see the acceleration of the disease process, and further workup with the CT chest will be recommended after discussion in the pulmonary MDT. And if this is the first presentation, then I would recommend the tissue sampling as well after discussion in the pulmonary
Excellent,
MDT.
Yavuz. Excellent, Yavuz. What about this device?
Sorry, the pacemaker is
Please,
seen, but
please,
it's
number one in your comment on lines and the tubes, okay?
yes.
Because maybe a safety issue present on lines and the tubes, okay?
Yes.
This device is what?
Pacemaker with its single lead pacemaker. I can see with its lead in the left ventricle.
Yes, yes. Single lead pacemaker, it's called, it's correct. This is called cardiac pacemaker or ICD, implantable cardiac defibrillator. This is a known question, by the way. A single lead, so it's a tip present in, are you sure, in the left?
Yes, it is extending inferiorly up to
Please,
the left
please,
tip
but
of.
if I said, are you sure? Just revise yourself, okay? It's
Okay.
present in the right. We place a cardiac pacemaker in the right, either right atrium or if dual device, right atrium and the right ventricle. No leads in the left, okay?
Right.
Okay, just my friends, revise cardiac pacemaker. We have a single lead, we have a dual lead, we have a biventricular. When I say biventricular, it is not in both ventricle, in right atrium, right ventricle, and in coronary signs. As you said, my friend, very good. We have reticulonodular opacities overlying both upper lung regions with some volume loss and pleural thickening as well. No hilar lymphadenopathy. Why I mentioned this point? Sarcoidosis on the differential. Okay, I want to correlate with the patient history. If there's chronic back pain, why? Ankylosing spondylitis in the differential. No linear opacity here doesn't have anatomical, non-anatomical linear opacity. No surgical clips. Why? Radiation pneumonitis, maybe in the differential or radiation fibrosis. I'm sorry. So when you mention the differential, just 1 point for every one. I will, I think I have a differential here. Yes, yes, here. Okay. Just I will revise. Yes, upper lobe pulmonary fibrosis. When you present with upper lobar reticulations, with reduced volume of upper and middle lung fields. What are the possible causes? Silicosis, progressive massive fibrosis. I want to correlate with any occupational history. Sarcoidosis, comment on both hilar lymphadenopathy, yes or no? Any cavitations for pulmonary tuberculosis, history of asthma, as as our friend mentioned. In younger age group, bronchiectasis and Bortacus, cystic fibrosis, one of the differential. In case of fibrous changes or fibrotic changes present predominantly in the lower lung basis. Shaggy border of heart, of the shaggy outline, the heart border, its definition of the diaphragm with reduced volume of lower lung fibrosis. IPF if no visible cause. If there is pleural calcification, think of asbestosis. Other differential may be related to CT scan. If hyperdense liver and cardiomegaly, think of amiodarone toxicity, calcific plaques or asbestosis. Dilated esophagus in the lower chest cuts, think of scleroderma and so on. You have to think in this way, upper or lower lung fibrosis. Okay, last case for you, yeah, boss. Yes.
I'm presented with radiograph chest frontal projection of an adult patient in which I can see that there is an area of nodular opacification involving the left lung predominantly upper and mid zones. I can also see that there is an area of circumscribed rounded opacity with central air lucency in bilateral apical regions as well, concerning for the cavity formation. And there is a relative sparing of bilateral bases. The hilar lymph nodes are not enlarged. The CP angles, they're clear. I can also appreciate a small nodule in the left lung lower zone as well. The heart bradycardic area does not show any abnormality. The bones, they are clear. And the trachea and airways that is in midline. So relatively reduced lung volume on the left side with opacification, reticulation nodules, and bilateral smaller cavities. My differentials will include, it could be because of infection, like recurrent infection like cystic fibrosis. I will keep in my differentials.
Cystic fibrosis in a younger age group. This is an adult, okay? Any other differential?
TB will be my tuberculosis.
Yes, on top of the list. Okay.
Yeah.
Tuberculosis because of cavitation, and also sarcoidosis may present with cavitation as well. This cavity doesn't include any nodularity within, so it's not fungal ball. Is this emergency or no?
So there is a relatively reduced lung volume on the left side.
This is okay. It's fibrosis with the cavitation, but the presence of cavitation, does it have any emergency? Yes or no?
Yes, it could result in the pneumothorax and concerning for the fungal infection.
Oh, okay. If you put a possibility of tuberculosis, two important points that carry high risk. One of them is this one. What is this?
Endobronchial spread of the disease process.
3-in-bud, yes. 3-in-bud is of high emergency. And the other one is this one. Cavitations. Cavitary TB,
right,
and or cavitation in case of tuberculosis, and the 3-in-bud nodules both carry high infectivity. So this patient needs what? 1, 2, 3, 4 mention.
So I will urgently, yes, I will urgently inform the referring physician for the isolation of the patient.
Excellent.
Acid fast specialist assessment of the sputum of the bronchopulmonary lavage, sibling screening, and further discussion in the pulmonary MDD for the management of the patient.
Excellent, Yavuz. Excellent. So this may be a safety point to be mentioned. So please, cavitations or 3-in-bud nodularity, consider it as an emergency. Very good, Yavuz. Thank you. Thank you. Okay,
Thank you.
Next candidate, still in the same.
Yes, sir.
Proceed, Yavuz.
I'm provided with frontal chest radiograph of a skeletally mature patient. I can see lobulated soft tissue opacities in bilateral hilar and suprahilar region and in bilateral lower paratracheal regions. There is also upward pull of the right hilar shadow. I can see
There is
fibrotic opacities.
yes, a buzzword here. Non-anatomical lateral border, well-defined lateral border. Is this anatomical structure? No, but
No.
it's relatively very well defined. Are you agree with me?
Yes, sir. I
Well-defined
can see
non-anatomical border. Yes,
okay, sorry. I can see surgical clips in the right chest wall.
excellent.
And I can see fibrous strands in the right upper zone.
Good.
Rest of the bones appear normal. I do not see any bony lytic or sclerotic lesion. So, summing up my findings, I can see a well-defined bilateral paratracheal and hilar soft tissue opacities with fibrosis in both upper zones. In the presence of surgical clips in a right chest wall, I am my most likely differential would be radiation fibrosis.
Excellent.
Uh,
Excellent. Okay.
I
It
will
is most
like
likely
to.
radiation fibrosis causing reduced lung volumes. Okay, but first comment on lines and the tubes. Okay.
Yes, sir.
Okay, this is central venous catheter for peripherally inserted, big peripherally inserted central catheter that's present inside at the area of atriocaval junction. Non-anatomical lateral border opacity centered on the mediastinum with apical fibrotic changes, reduced both lung volume, surgical clips. This is most likely related to maybe cancer breast with radiation. Okay, but yes. Dr. Nurhan said spine is normal. Okay. I'm not sure if spine is normal or no, because there is something deviation here. I'm not sure. I'm not sure. This spine is يعني needs lateral. I see lateral. Yes. Okay. Ignore it. Ignore it. It's not clear. It's not clear. Okay. Second case, yeah, boss.
I'm provided with the frontal chest radiograph of a skeletally mature patient. I can see there is reduced lung volumes on both sides. Multiple reticular opacities are seen in both lungs with more zonal distribution in the mid and lower zones. Um, I can also see some nodularity along the right horizontal fissure. Uh, the There is no sparing of the lung bases or the costophrenic angles. Both costophrenic angles appear normal. There is no evidence of pleural effusion. The cardiac contour appears normal. The hilar shadows appear normal. There is no evidence of hilar or paratracheal lymphadenopathy. The visualized bones appear normal.
Okay,
So
CT scan, same patient.
I'm provided with the CT scan of lung window axial images. I can see multiple reticular opacities in subpleural distribution without areas of subpleural sparing in both lung bases, which is associated with honeycombing and traction bronchiectasis. Uh, no,
Diagnosis.
if this patient is an elderly patient, then I would think of a usual interstitial pneumonia pattern, which is suggestive of idiopathic pulmonary fibrosis. If this
Excellent, Babos.
patient
Yes,
has, I'm looking for any calcified pleural plaques, but I do
excellent.
not see any calcified pleural plaques, in the absence of which I will rule out the possibility of asbestosis.
Good.
If this patient has a history of amiodarone for any cardiac condition, then this could be due to amiodarone related lung toxicity. Uh,
If you
and
see dilated esophagus with
and if
subvocal sparing,
then it could be due to scleroderma induced non-specific interstitial pneumonia.
okay. And as you mentioned, if you see a dense liver with cardiomegaly, amiodarone toxicity. Very good approach. So if you see here a diffuse reticular pattern, but predominantly at lower zone with shaggy irregular border, ill-defined or shaggy outline of the diaphragm as well. These changes with fibrotic change. we have to put a list of differential. But here, no calcific pleural plaques. Also from chest CT, mentions the finding of IPF, the typical finding. Honey combing, traction bronchiectasis, irregular septal thickening. It includes the pleural surface. Very good item. No subpleural sparing, unlike this case. There is subpleural sparing and dilated esophagus. This is scleroderma. It's fibrotic, non-specific interstitial pneumonitis. But here, the usual interstitial or IBF, UIB pattern. Other causes like this patient with cardiomegaly, CT revealed hyperdense liver. What are other differential of hyperdense liver, my friend?
It can be in hemochromatosis.
Younger patient, yes.
It can be in Wilson's disease, amiodarone toxicity, copper deposition,
Excellent.
hemosiderosis.
Excellent, yes, excellent. Just revise some differential. Okay. Do you want me to continue? We covered now the last one of this group. Volume loss may be related to pleural thickening, collapse, fibrosis, or a pneumonectomy. I am with you. Okay. Want me to proceed?
Yes, sir.
Okay.
Yes.
Okay. Let's proceed to another group. Just a minute, I will close this group. Okay. Now we will talk about a hilar lesion or a hilar mass. We comment on both hilar. If you noticed hilar enlargement, comment on the bilaterality and symmetry. If you see a bilateral hilar enlargement, it's rather symmetrical, lobulated borders. This is a very common exam case and relatively common in practice also. It may be related to sarcoidosis. In such case, comment on the right paratracheal stripe, sometimes aortopulmonary window. 1, 2, 3, 4 sign. 1 to 3 is relatively more common. It's called Garland's triad. Normal vessels can be seen through because the mimicker of this lesion is pulmonary arterial hypertension. Differential diagnosis, sarcoidosis on top of the list, but maybe lymphoma, usually bilateral, asymmetrical. TB, usually unilateral. Hilar enlargement if unilateral, unlikely to be lymph node. It may be central bronchogenic carcinoma. It may be a hilar mass like in lymphoma. Okay, so in case of hilar enlargement, comment if there is bilateral, symmetrical, or asymmetrical. If it continues with the vessels or no, if there is associated cardiomegaly or no, because this is related to pulmonary arterial hypertension. And this is the causes of nodal enlargement as well. The last item in this group, it's a common question in CT scan. In CT scan, patterns of sarcoidosis. In X-ray, the stages of sarcoid, okay, and in CT, a pattern of sarcoid. The commonest pattern of sarcoid after hilar lymphadenopathy, nodules. Nodules along the perilymphatic or peribronchovascular. Sometimes nodules aggregate forming galaxy sign, and sometimes it's associated with upper lung fibrotic bands. These are the common questions about hilar enlargement. Now let's start. Okay, who will start? The last candidate, I think.
Yes, I'm here.
Okay, proceed, boss.
I'm presented with a frontal chest radiograph of a skeletally mature patient. I can see bilateral symmetrical